So we'll keep in the same subject. Much of what I'll be saying has been said already, but still, there's still room for some more information, I guess. These are my disclosures. So, what is this? What do we have here? A plastic bag, a plain simple plastic bag, perhaps you would say, and in fact it is, but it's a very good example of what happens to the shoulder capsule every time a shoulder dislocates. It's this plastic deformation of the capsule that remains after several dislocations that we have to bear in mind when deciding what to do to a shoulder that has been dislocated and needs surgery. There are several types of anterior labral and ligamentous structural lesions, as you will know from plain simple Bankart lesion. May have bony Bankart, you have Burt's lesions, you may have Alpsa lesions, Glad lesions, or you can have the Hagel lesion, which should not be missed, because if you miss it and if you go for a plain simple Bankart, then you may have a failure of that procedure. Now, these are signs of internal impingements that, in fact, may come along with any unstable shoulder. It's that pinching between the glenoid and the humeral head that leaves that fraying in the labrum. As you will see in a while, this case also has detachment of the capsule from the humeral side. So there's a torn capsule that should not be missed. Otherwise, if you go for a simple Bankart, it's highly likely that this repair will fail. Now, most of the times, one will be discussing between doing a Bankart or a Latagé, but in fact, there's a lot more than that to discuss. But should you leave the decision to the OR? Should you decide intraoperatively, or should you stick to scores like the ISI score, which considers several risk factors, but also imaging exams only on X-rays, or should you go a little bit further in terms of imaging workup, like with an MRI or a CT scan? Well, perhaps you should. So that you can have a proper assessment of the glenoid tract, as we've been saying up till now. And what's the importance of this? If you have a non-tract lesion and a minor glenoid bone loss, whether that's below 25% or 10% or 17%, as some authors say, that's another story and no different discussion, then probably going for a soft tissue repair or simple Bankart could do the job. But if you have an off-tract lesion, you should add something else. Perhaps a remplissage will be needed. On the opposite side of the spectrum, if you have a major glenoid bone loss, then some sort of bony augmentation, like the Latagé, is mandatory. Now, what do we know about comparisons between these two procedures, doing a Bankart or an open Latagé? The recurrence rates are not very different. Apprehension and revisions are also kind of similar, but we have to bear in mind that there are very large variations in the literature that depend a lot on the patient selection. So there's a clear selection bias in all these studies, so one has to be judicious when reading these articles. We have classical long follow-up series, like Ophelia series of patients after 17 years that did very well with Latagé. So the Latagé presented with better recurrence rates, patient satisfaction, and clinical scores. Also, this one after 6 years, in which the recurrence rate after a Latagé was better than after a Bankart. And quite interestingly, the Latagé failed only in the first 2 years, whereas the Bankarts kept failing. So this is very important as well, which means probably that we should add something else when going for a soft tissue procedure, like adding a remplissage, dynamic anterior stabilization with the biceps, some sort of augmentation with a subscap, or labral augmentation, like Maristella just said. And probably these additional procedures may lead one to have better results in the near future. And what do we know about comparisons between doing Latagés and remplissage, which are classical procedures? This laboratorial study showed that in glenoids with about 25% bone loss, the stability was similar. But this was a laboratorial study. This one is a clinical one, which reached similar results. So one would have similar results between the two. However, in revision cases, probably the Latarjet does better. So the rationale behind surgery should be something around this. If you have no bone loss, then restoring the anterior capsule and labrum should do the job. If you have humeral bone loss, then one should reduce the posterior capsule volume with the remplissage perhaps. If you have anterior soft tissue deficiency, hyperlaxity, minor glandular bone loss, then reinforcing the anterior structures may do the job, like augmentation with subscap and or with the long biceps. But if you have an important glenoid bone loss on the glenoid side, then you should use some sort of bony augmentation. Now, this interesting recent study showed by these experienced surgeons that the recurrence was common after an isolated Bankart despite subcritical glenoid bone loss below 15%. So they stated that the remplissage may even be considered in on-track lesions. So for these experienced surgeons, there's not much room for an isolated Bankart today. So this is just an example of remplissage. There are quite a few ways of doing it. I tried to make it simple after a few years. So placing a couple of metallic anchors, I think the purchase is better with this kind of anchors. I get rid of one of the sutures, so this was a double-loaded anchor, but I just used one of those. And then place the second anchor closer to the tendon than to the cartilage to avoid stiffness. And then with a double pulley technique, just tie the knot blindly in the subacromial space, and that will do the job. And obviously doing the Bankart repair. So after beginning with the preparation of the anterior capsule and labrum, all the detachment, then just fixing the labrum classically, just brought it here because I'd like to show you that I like using knotless anchors and soft knotless anchors. I think they perform quite well. It just diminishes the number of steps, so potentially it also diminishes the potential for errors and just makes it simple. And this is a knotless anchor that allows you to estimate the tension, which is one of the reasons some surgeons would not like knotless anchors, but of a different kind. As you can see, by estimating the tension, you can see the taut anterior band of the inferior glenohumeral ligament. And then moving on to the second anchor and third anchor, and this will work fine. So the reason why this should be done at the end is that preparation of the Bankart and the labrum at first, because you have more room, then close the remplissage and get back to the anterior part of the capsule, of the joints, to complete the procedure. Now, this is an interesting recent study as well from a group of experts. They tried to reach a consensus around this topic. And in fact, of all the statements they defined beforehand, they found unanimous or strong consensus in most of the statements, but there was no unanimous agreement on any aspect around the Latarjet or the remplissage. So clearly there's a lot to know about this topic. And considering that remplissage is best for glenoid bone defects below 10% and large off-track lesions, these authors and others have proposed using that same sling effect with long biceps instead of using the conjoint tendon for that purpose, aka the Latarjet, in limited glenoid bone defects under 20%. And they would indicate this in instability, limited bone defects, unstable painful shoulder, in cases of hyperlaxity, associated slaps, so potentially in those cases you will do something to the long biceps anyway. And this is just me saying, perhaps in a revision of a Latarjet. This is a case of mine which failed after about 1 year after a Latarjet, and the CT scan showed the bone graft healed in a good position, so I assumed this was a soft tissue problem, and maybe there would be room for a dynamic anterior stabilization, and in fact, I think there was. The clinical result was fine. It's hard to see, but there's an anchor in the X-ray below, in between the two screws, and this patient did fine. And this is the way I do it. This is not the same case. This is a primary case. So as you can see, there's a slap lesion there. So surely something will be done to the biceps, Bunkert, and plication of the anterior part of the capsule, and then tack stitching the long biceps, cutting the transverse ligament till you dislocate anteriorly the long biceps, and then do the split on the subscap with the radio frequency 1, like so, and then cutting the origin, the insertion of long biceps during the tenotomy, passing the sutures that are tack stitching the long biceps through it from anterior to the joint, then pulling it from posterior using a grasper to help you out. Next step, grabbing those sutures through the rotator interval cannula so that I can use them to fix the long biceps on the glenoid rim. This is a punching anchor with which you can estimate the tension that makes this kind of fixation quite easy. There are other techniques you can use for this procedure, but I like this one because I think it makes it a lot simpler and leaves room for the Bankart repair at 5 and 6 o'clock. And this is the result of a fixed long biceps through the subscap. So as final messages, the recurrence rates vary widely. Do not underestimate the importance of bony lesions. Marcela said do not underestimate the soft tissues, but the bony lesions as well. Latagé is more reliable. That's something one should not forget, and keep stable after 2 years. But we also know that today the choice between one technique or the other depends a lot on the surgeon's preference or training. But we have newer techniques today that may change the rationale for decision.